Very good evening, everyone. A warm welcome to you all for the second session of live webinar, our master classes in critical care medicine from Yashoda Hospitals in association with the IFCCM Hyderabad chapter. Today, our case discussion is burns, topic for discussion. And we have our senior faculties, two senior examiners, Dr. Subba Reddy sir, he is a senior consultant and HOD from Apollo Hospitals. And another examiner is Dr. Suresh Ramsubban sir. He is also very senior consultant from Apollo Hospitals, Kolkata. And burns is a very important topic for exam and as well in our critical care practice also. So now I will hand over the mic to Dr. Venkat sir. He is our clinical director. He will talk on burns and then we will start the session.
Yeah, good evening and thank you, Dr. Shashidhar, in inviting me. See, what we actually tried to focus on is if you look at our cases from the first case to burns case now, and we are also looking for a trauma case. When I was a part of examination, what I realized is many of our students who are practicing in many of the metro hospitals may not come across all the spectrum of cases, particularly when it comes to the poisoning, when it comes to the burns, when it comes to the trauma, when it comes to the obstetrics. These may be limited to a few referral centers and may not be a common cases for most of you, including some of those cardiac cases or post-surgical cardiac transplant cases and all. So we felt these are the areas where many of our students struggle when these kind of cases unexpectedly turn to be a part of their exam. So we thought we should bring seasoned examiners to discuss these areas first. So we brought these cases as a part of it. So burns is among those cases which are not commonly in all the ICUs. Many centers may not actually accept the more than 40% of burns in their area or in their ICU. And burns needs a specialized unit or intensive care area to cater. And over a time, we have seen key burns, probably mass casualties on burns related injuries has gone down, but it's still a part of our ICUs on and off. So to bring this topic, we actually thought one of our student, Dr. Karthik, who is the final year DNB student, to present a live case, which will create some discussion like an exam pattern. And Dr. Subba Reddy and Dr. Suresh Ramsubban will be guiding you through this exam. Dr. Suresh Ramsubban was held with some VIP emergency. So he will be joining us soon. Till that time, I think we will start the case with Dr. Karthik. And before that, I will invite Dr. Subba Reddy, who is our examiner today's for the session, to actually put few words, because I know he has been also a part of managing few very sick high percentage of burns cases with precision and making those patients survive. Over to you, Dr. Subba, to guide your student.
Thank you, Dr. Venkat, Dr. Shashidhar, for that introduction. And thanks to Yashoda Hospitals and Indian Society of Critical Care Medicine, IFCCM Hyderabad branch, for bringing these sessions, which are very, very useful to the students. I must congratulate both IFCCM Hyderabad and Yashoda Hospitals for these wonderful, lot of wonderful sessions, and a lot of students across the country are getting benefited. Even the first session I have seen, and then it is very good. So as Dr. Venkat said, burns we routinely don't see in all the hospitals. We have separate dedicated burns unit. And then these patients, more than 15% burns, lot of centers, they try to refer the patients to the burn center. And that's why we don't come across these patients very often in our intensive care units. And today we'll discuss burns case, which is a very, very important case for your IDCCM exam and even FND exam. And how to manage burns patient, how to do resuscitation and nutrition, and if the patient goes into sepsis, how to manage, and what kind of dressings we have. So those things we will discuss. And before discussing this, I think right now we have one patient with 40% burns, similar to this case, and the patient is with us since last 55 days, 60 days, and then patient is recovering. And you need a multidisciplinary approach when you're dealing with a burns patient. You need good intensive, first ER, good resuscitation in ER, and then good intensive care. After that, you have to involve plastic surgery team and plastic surgeons also, those plastic surgeons who routinely take care of burn patients, who are experts in taking care of burns patients. And then we have a lot of dressings available. We have biological dressings, and then we have cadaver skin available nowadays. And skin is a very, very a very important organ. If the liver, 60% of the liver is damaged, still the patient can survive. But if the patient skin 40% burns and more than 40% burns, again, the mortality will increase. So you need a dedicated burn center, good intensive care to manage these patients. And then you should have thorough knowledge by the time you complete your critical care fellowship about burns. Shall we go ahead with the case presentation?
Yes.
Thank you, sir. Good evening, sir. I'm Dr. Karthik, critical care DNB, final year, sir. Today's case is there was a 72-year-old female patient was brought to the ER with alleged history of flame burns during puja at 8 a.m. on 6-1-22. She had burns all over the back, neck, and both upper limbs and the left thigh and right calf. Patient complaints of severe pain, burning in nature, and there was no difficulty in breathing. There was no history of fall, loss of consciousness, or altered mentation. There was no history of difficult speech, swallowing, or hoarseness of voice. Sir?
Yeah.
And in the significant past history,
can you go back to your previous slide?
Yes, sir.
Yeah. Tell me, Dr. Karthik. So here at this stage, how do you calculate the percentage of burns, and then this patient is having how much percentage of burns?
Sir, after the primary and secondary survey, sir, according to the rule of 9, this patient had approximately 70% burns, sir.
Approximately 70% burns.
Sir. Yes, sir.
How much?
Yes, sir. Yes, sir.
No, how did you come to that 70%?
According to the rule of 9, sir, rule of Wallace, rule of 9. Sir. According to the rule of 9, sir, rule of 9 says the face is 9%, both upper limbs.
But you said it is only neck, not face.
Yes, sir. Yes, sir. For this patient, sir, the trunk is 18%, sir. Back is 18%, which comes to 36%. Both upper limbs, sir.
You have to be very clear. It's all over the back, but not in the anterior portion, right? Only in the posterior portion.
In the front also, sir. This patient had in the front.
Okay, so then
36%. Both upper limbs 9 and 9, sir.
18.
Yes, sir. 54%. Right calf on the lower limb, sir. Right calf and right thigh, left thigh were involved, sir, which comes to 67%, sir. Neck we have taken as 3%, so approximately 70% for this person.
Approximately 70%.
Yes, sir.
Okay. And any signs of inhalational injury?
No, sir. As of now, this patient didn't show any signs of inhalational injury, as there was no altered mentation. There was no soothe or no singing of nasal hairs. There was no facial burns or no black discoloration of face or anything, sir. And there was no change in voice. There was no change in no use of accessory muscles of respiration, or facial burns also were not seen, sir. So I thought it was not a inhalational injury, sir.
Okay. Then next slide.
Significant past history: known hypertensive, diabetic, and CAD on regular medications, and history of hysterectomy 25 years back. On examination, the patient was conscious, coherent.
At that point of time, so you are in ER. You started resuscitating the patient, and then you started resuscitation, and
Yes.
the family is asking you, how do you do you think patient will survive? 72-year-old lady with 70% burns, and do you think patient will survive, or what are the chances of survival? So how are you going to prognosticate at this point of time?
Sir, rational with the old age group and more than 40% burns, it is 30 to 40% of mortality, sir. If there is an additional inhalational injury, the mortality rate increases, sir. The prognosis would be bad for this particular patient, sir. That is what I would tell the attendants.
Instead of saying bad, is there any formula to prognosticate this kind of patients? Do you know any formula?
For prognostication, sir.
Yeah, for prognostication, there's a formula called box formula, BOAX, box formula. And this formula is based on the age of the patient, okay, plus percentage of burns. And if you think the age of the patient, age of the patient is 72, and then if you think the percentage of burns is 70%, then if you combine, then it comes to 140. And then according to box formula, if the score is 140 and survival is very, very poor, so the mortality is very high, more than 90%.
Yes.
So, and then if there is any inhalational injury, then you have to add another 17 score for this box. That is called modified box formula. Okay. And the disadvantage of this formula is it doesn't include any comorbidities like diabetes, hypertension, and this patient has diabetes, hypertension, and coronary artery disease, elderly lady. So these are the factors, and then the prognosis comes very, very, very bleak, very, very poor prognosis. So the prognostication is very important. Why prognostication is very important? Because you need to tell them the chances of survival, and you have to talk about everything. You have to talk about resuscitation. You're talking about after resuscitation, you'll be talking about the ICU care, how many days the patient is going to stay with you in the hospital. How many days do you think this patient is going to stay with you in the hospital?
Sir, this patient, if everything is going good, probably for 2 months or so.
Approximately 1.5 day per each percentage.
Degree of burns. Yes.
Yeah, degree of burns. So if it is 75%, then
90 days.
Around 90 days, the patient will stay with us if everything goes smoothly without major infections and all. Okay. 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 Then go ahead.
Sir, on examination, patient was conscious, coherent, and tachypneic in state. Her vitals were heart rate was 108, respiratory rate was 26, BP was 160 by 100, and SpO2 was 98% in room air. On local examination, burns on the neck were second degree burns on the trunk and back, second to third degree mixed burns on both upper limbs and anterior and posterior side, second degree burns on the right thigh and left calf. According to rule of 9, it was 70% mixed burns, sir. No SR was seen. Skin over the surface was red, white all over the red and white over the right upper lip. Surrounding skin was normal and no blisters were seen. Edema, blisters or edema was seen, and singing of hair was present on the body.
So at this point of time, so how did you resuscitate this patient in ER?
Sir, ER first I have taken care of the ABC, sir, airway, breathing, and circulation. First, I have seen whether the patient was.
What is A, B, C, D, E in burns? What is D and E?
D is disability, sir, and E is exposure, sir.
D is depth of burn and E is the extent of burn.
Okay.
In A, B, C, D, E.
Okay.
Okay.
Sir, airway first. Airway was patent for this particular patient, sir. And breathing also, she was adequately taking, and there was no difficulty in breathing. She was mild tachypneic, sir, probably because of pain. And circulation, I would take 2 large bore IV cannulas, and I would place 2 large bore IV cannulas, and then resuscitate her with balanced salt solution, sir, according to Parkland's formula.
Okay. What is Parkland formula?
Parkland formula is the resuscitation fluid, amount of resuscitation fluid required for a burns patient, sir, which is 4 ml per kg body weight per percentage of burns, which should be given at half of which should be given in 8 hours, starting from the time of onset of the burn to 8 hours, followed by the rest of the half in 16 hours.
Okay. And any other formulas,
Modified Brooks formula is there, sir. Modified Brooks formula says it is half of this amount, sir, 2 ml per kg body weight of ringer lactate solution per kg per percent of your burns. Modified Brooks says 1.5 ml per kg body weight of ringer lactate, 1.5 ml of ringer lactate per kg body weight per percentage, plus 0.5 ml of plasma to be added to this, along with 5% dextrose of 2000 ml, sir. They should be added in first 24 hours. First half should be given in 8 hours and the rest of the half should be given in 24 hours.
Instead of FFP, if I want to give 4.5% albumin or 5% albumin, how should I, is there any formula for that, or what is the rationale of that?
Sure. Muir and Barclay formula is there, sir, for that. They have taken in 36 hours for this, sir, 4.5% albumin, which was given at percentage of burns into weight divided by 2 is the total ml of albumin required, which should be given at aliquots at different hours, sir, within first 4 hours, followed by 6 hours, followed by 12 hours. Murray and Barclay formulas.
Okay, so what is the advantage of colloids giving like albumin? What is the role of albumin, and why do you give albumin?
Albumin has higher oncotic pressure, sir. So the amount of fluids which we give is on the lower side. So abdominal compartment syndrome is lesser seen in these patients, and lower amount of volumes can be given. And the intravascular volume also is, it stays in the intravascular space for a longer duration than the colloids, than the crystalloids. Okay.
You might have heard about fluid creep, right, in burns.
Yes,
and do you think this Parkland formula is universally applicable for all the patients, or some patients it can cause fluid creep?
Yes, sir. In pediatric patients and in few patients whose intravascular volume is not that low, if we give the total amount of Parkland formula, there is lots of third spacing and it causes fluid creep, sir. So the amount of fluid which is actually calculated in Parkland formula, for most of the patients, it comes to a larger volume status than the actual required volume.
So you try to over-resuscitate with Parkland formula in some patients, right? So yes, what are your strategies to prevent fluid creep in burns patient? So how do you monitor your fluid therapy in burns patient?
I would like to see the clinical parameters of the patient, sir, like urine output, maintaining approximately 0.5 ml of kg body weight for an adult and 1 ml per kg body weight for a child. I try to see the heart rate. If it is coming down and heart rate of target less than 110 after adequate analgesia should be done. That is my target, sir. And adequate MAP also to be maintained, sir.
Okay. And what strategies do you have if the patient is developing edema, generalized edema, or anasarca? Then what strategies you have to slow down the resuscitation to prevent fluid creep?
To prevent fluid creep, I can use albumin, sir.
Okay.
I can use diuretics, sir. If at all my fluid overload is there and vascular volume is okay, then I can use a diuretic. Or if at all the patient is developing abdominal compartment syndrome or any other places where their compartment syndromes are developing, then I would try to manage those things accordingly and try to decrease my fluid levels at 10% per hour as I go ahead.
So one strategy is giving albumin. In most of the studies, they were given 4.5 to 5% albumin. And we don't have, like we have, but in some centers, we have 20% albumin. But giving diuretics may not be a good choice because these patients are prone to develop AKI. Okay. So giving diuretic is not an answer, because here they develop edema because of endothelial dysfunction and because of the capillary leak. Diuretics may not help. So do you know any other medication maybe having some evidence but not great evidence to prevent this capillary leak and preventing fluid creep in these patients? Did you hear about vitamin C?
Vitamin C, sir. Yes, sir. Yes, sir. Tanaka study that has come, sir. That study has shown a decrease in the fluid requirement and easy resuscitation of these particular patients, sir, decreasing.
So they have given, in one study, they have given 66 milligrams per kg per hour of vitamin C. And then they found reduced prevented over resuscitation and prevented capillary leak. And then any role for FFP in preventing fluid creep when you don't have albumin? I think in audience, if you have any questions, you can put it in the chat box. And I think somebody answered modified box score. It is not BOX, it is box, BOUX box score. And the Vignesh is asking, is there any role of FFP in preventing fluid creep? FFP tried, did you try in this patient maybe? Yeah.
No, sir. In this patient, we used albumin, sir.
So you used albumin, and one strategy is more than 40% burns. Generally, albumin can be used. Albumin or FFP can be used to decrease the fluid creep. You rightly said that you used albumin instead of FFP in this patient. Okay, good. So go ahead with the next slide. Go ahead with your presentation. So what did you do for the burns, for second degree burns, third degree burns, and all? What did you do?
Sir, first is we maintained adequate. Sir?
Yeah, I can hear.
First is we maintained normothermia for this patient, sir. Then adequately resuscitated with IV fluid.
Why did you say normothermia?
Burns patients, they are more prone to go into hypothermia because of this particular patient had extensive burn, so lots of fluid, insensible fluid loss, and the skin.
What is the room temperature for this patient when you are managing? What is your ER temperature?
Sir, ER ambient temperature should be at 90 degree Fahrenheit, sir, which comes approximately 32 to 34 degrees centigrade, sir.
28 to 32 degrees is the appropriate temperature for preventing hypothermia in burns patient. Okay. So what is lethal triad in burns and trauma?
Coagulopathy, acidosis, and hypothermia, sir.
Excellent. This lethal triad is applicable for both burns and trauma. It increases mortality, so we have to prevent burns, hypothermia. Yes, good. And then what else you did?
For this particular patient, after that adequate resuscitation, we have maintained a strict barrier technique and strict aseptic techniques to handle the patient, sir. We have started them on stress ulcer prophylaxis also, sir. Then IV fluid therapy, stress ulcer prophylaxis. Then Foley's catheter was placed for this patient to see the adequate urine output.
Very good.
And further cross consultations with the plastic surgeons and all were taken. And first in the ER, the clean water wash was given for this patient, sir. Later, after that, we have applied collagen dressing for this patient, sir.
Excellent. Okay. Did you see any time chlorhexidine gauze dressing applying?
No, sir.
Okay, we'll go to the next slide.
No soot on the mouth or nasal cavity was present. Room air saturation was 98%. Tachypnea with 26 was there, sir. And on auscultation, bilateral air entry was present with no wheeze. CVS, CNS, GIT, and vision was normal for this patient, sir.
Okay. Yep. Well, what are the other systems can be involved in a patient with major burns like this? What are the effects on GI system? What are the effects of major burns on the cardiovascular system and on hematological system? Can you go twice? Yeah.
Yes, sir. In early phase, sir, in the ERBS phase, in the first 48 hours, in the CVS, there is tachycardia, sir. Cardiac index is low, stroke volume is low, BP may be normal or low. pulmonary vascular resistance and systemic vascular resistance are high. Hematocrit may be high. Patient may have metabolic acidosis, and when done in an echo, the patient may have small chambers and decreased contractility in the first 48 hours, sir, in CVS. After 48 hours, generally the cardiac index improves and the SVR decreases, sir, in the flow phase.
Yes.
And coming to the renal system, sir, the patient may go into oliguria or myoglobinuria may be seen in patients, sir. And after 48 hours, the GFR generally increases and tubular filtration also generally increases, sir. And patients with this inhalational injuries or chlorosis injuries, they may have altered mental status when it comes to the brain, sir. And coming to lungs, the patient may have inhalational injury, ARDS like picture, pulmonary edema, they may have bronchospasms, bronchorias, and all those things, sir.
Okay. And GI system?
GI system, sir, generally in GI system, the gut edema may be seen in few patients, sir. And if the other type of injuries are there, then charring also may be seen, sir. Chemical burns injury and all.
And these patients will have ileus also. Ileus also, that's why you start enteral nutrition as early as possible, so that it stimulates the splanchnic circulation, and then the ileus will get better. But if the gut tolerates. Okay. Okay. And any other system? Renal? Did you cover renal?
Yes, sir. Myoglobinuria or oliguria may be seen, sir. At a later phase after 48 hours, the GFR generally increases.
What, Karthik, what are the different mechanisms of burns injury you face? What are the different kind of burns injury we face?
Thermal injuries may be seen, sir. Electrical injuries, chemical injuries, cold frostbite we can see, sir. Radioactive injuries we can see. Then scald injuries we can see.
Okay, frictional, flame, and chemical, irradiational, all this. So yes. You're speaking about the different grades or degrees of burns. So how you classify the depth of burns?
Sir, depth of burns can be classified as first degree, second degree, and third degree burns, sir. Generally, superficial burns are first degree burns where only the dermis is involved. In the second degree, only the epidermis is involved, sir. In the second degree burns or the deep burns where the epidermis and the first layer of the dermis is involved, and in the third degree burns, the lower layers of the dermis can be involved. In fourth degree, the muscles and bones can be involved, sir.
So how do you assess or estimate this thickness or the injury?
Sir, actually Doppler can be done, sir, or infrared thermography can be done for this thickness of the
can be done? What Doppler can be done?
The thickness Doppler, sir.
It's called laser Doppler analysis. It's not regular Doppler, which can use. What are the other methods to assess this thickness?
Transcutaneous video microscopy one is there, sir. Infrared thermography is also there, sir.
So they also use indocyanine green IV therapy, thermography. A number of dermoscopes are there. So these are all more accurate methods. See, even a visual eyeball rolling, we may actually estimate these different thicknesses that may not be always accurate. Okay. You also spoke about the percentage of burns. You only spoke about the rule of 9. Okay. How accurate is that? What are the better methods than rule of 9?
London Broader method is there, sir, where it can take the total body surface area, and better in pediatric patients also, sir, where it has a formula.
How do you actually know that area? So rule of 9, you know, it is all divided. What is London Broader classification?
London Broader, they have given ABC for face, the trunk and the legs, sir. The other areas they have given 3%. So as the body surface area increases, they have a scale which increases the percentage of burns, sir. So from pediatric to adults, the percentage of burns increases in the class A, class B, class C as the chest the body surface area increases. So because of that, the accuracy of percentage of burns is better in London borders.
So in rule of 9, in which patients you may go wrong? What are the areas which you may go
Pediatric
wrong?
patients. Pediatric patients, sir.
Okay, and which are the patients which may even give you a adult patient which you give a wrong impression in rule of 9?
The emaciated or thin-built patients.
No.
Obese patients, sir.
Obese patient, large breast surface areas, those are the patients which can actually mislead to you.
Yes.
So anatomical location, how important is it to anatomical location?
Sir, even a small percentage of burns may create a larger disability to the patient. If we think about 1%, 2% burns at a hand, the disability for that particular patient may be very high. Or the only face burns. That there even the percentage of burns, if it is low, there may be a larger airway difficulty, or the risk for the patient may be very high. So it doesn't depend on the percentage of burns, but the area of burns and the place and the depth of the burns which decide the...
Which anatomical locations are considered to be more threatening when it comes to the burns?
Face and neck, sir.
Okay, anything else? Can I have a respiratory tract burns?
Yes, sir.
When it happens?
In this hot inhalational burns can see.
So heated air, a superheated air, when it actually been blowing,
yes,
then
sir.
that can also cause that. So
Yes.
there is another part. See, when you see a burns case with a mass casualty or a burns in a any infrastructural building, what are the
Sir.
other add-on injuries or other add-on things which we'll look at in these patients?
Generally, other traumas, sir, how the patient was taken out from that particular area, whether there was a blast injury and the patient was thrown out, or whether the patient jumped out to save himself, or so. So the head-to-toe examination for other injuries have to be seen, sir.
Okay, so what are the, actually these patients are considered to be, if they have a cervical spine injury,
Yes,
altered sensorium, those need to be also taken care in case of a mass casualty or a burns
Yes.
in a large building where a lot of patients were been evacuated. So burns associated with trauma is also. Suppose a burns patient comes with an altered sensorium. You spoke about A, B, C, D, E, as
Yes.
Dr. Subba rightly pointed out. So if a patient with a burns history is an altered sensorium, so along with the burns, what are the other things you should be considering in your mind?
Sir, inhalational injuries or hypovolemia, which may cause altered mental status, both of these should be
What
kept in mind.
inhalational injuries you are suspecting?
Carbon monoxide poisoning and cyanide monoxide poisoning should be kept
Which
in
are the
mind.
context where you'll suspect carbon monoxide and carbon cyanide poisoning?
Sir, in a closed room space flame injury, there I will keep in mind about these poisonings, sir.
Which
This
poisoning?
carbon monoxide
Cyanide poisonings?
Generally, it is along with that only, sir. But when tire combustion and all those things there, then we'll think.
So how do you differentiate? How you diagnose a carbon monoxide or a cyanide poisoning?
Sir, by ABG, if we have a co-oximetry, sir, in co-oximetry, carboxyhemoglobin will be on the higher side, sir.
How do you classify carbon monoxide poisoning?
Carbon monoxide poisoning, it is the normal levels are less than 15, sir. 15 to 30.
Normal levels are less than 15?
Less than 1, sir, but till 15 it is not lethal, sir. Above 15. So till 15 it is mild, sir. 15 to, again they have classified as 20, 20 to 30, 30 to 40, sir. So 15 to 40 is moderate, sir. More than 40 it is severe, sir.
So you need a co-oximetry to identify.
Yes.
So how do you actually identify a cyanide poisoning, or when do you suspect a cyanide poisoning? What will happen to your peripheries? What will happen to your mucous membrane? What will happen to your ABGs?
Yes, sir. Bluish discoloration in cyanide poisoning, sir. Cherry red discoloration in carbon monoxide poisonings.
Why is that all happen?
Because the oxygen carrying capacity, the carbon monoxide is it has higher affinity towards hemoglobin, and it is attached to the hemoglobin, and it circulates, sir. Whereas in cyanide poisoning, the oxygen dissociation is not properly. So there is venous hypoxia in
cyanide is a histotoxic cyanosis or a kind of anemia. So these are the contexts which will be again a part of your exam, Karthik. So it is not just burns. We have seen many patients when they come to our casualty in a mass casualty, either in a building fire evacuation or in a mass casualty. There can be you can have a stampede, you can have a jumping of the building, you can have a blast injuries where you have a burns with trauma, with amputation, with burst. So many things can overlap. What do you think, Dr. Subba? There will be the real-time situations may be completely different. So in exam point of view, you need to actually know not just about burns, but the context in which this patient has been coming to us. So as ABCDE, you need to keep all these things in mind. So we had a patient where you may be having a very minor degree burns, but the patient was unconscious, and that patient, when imaging was done, had a very massive traumatic brain injury with the intracranial contusions and bleeds. So, and few patient may have a cervical injuries with a quadriparesis wherever the burns was minor. Stampede causing a multiple intra-abdominal injuries causing hemoperitoneuria. So there can be an overlap of 2-3 things which can actually cause this burns patient more complex. So those are one areas which you need to keep open in these situations. Over to you, Subba.
Yes, sir. I completely agree with you. And so that's why ABCD is D for depth of burns and D for the disability. You need to monitor the pupils. And then if the imaging is required, if the patient is an altered sensorium, we must do imaging. Sometimes you see subdural hematomas, sometimes you see cervical spine injuries, sometimes you see contusions, as Dr. Venkat said. So you should not go with, or you should not think it is only because of carbon monoxide poisoning or something, or hypoxia. Like we have, if required, we need to do imaging for the patients. And there are some questions in the chat box. They answered some questions, tire combustion, types of hypoxia. Dr. Mahesh answered. One is a tissue hypoxia, and the other one is carrier-mediated hypoxia. And Dr. Unduti Das is asking about, did you measure plasma insulin was estimated, or any plasma IL-6, TNF measured, and the plasma lactate was done? And plasma LPS by endotoxin was done, or endotoxin was done in this patient. So any role do you think, Dr. Karthik, for this, or like for this, any role? Do you know?
Nearly all of the burns patients, more than 15 to 20% burns patients will by default be having a cytokine release, and they will have a CIRS response. So ideally, IL-6 and TNF won't be measured, sir.
Yeah, and there is one theory that if you measure this LPS endotoxin, so the it will tell you indirectly about the myocardial contractility, and then the patient is if the patient is going into heart failure, this predicts the patient going into heart failure, myocardial contractility. And in some centers, some case reports they use, they have seen when they measure the IL-6 and when they have seen a cytokine storm, they use cytokine filters in these patients early. But there is no good evidence still on this. So we'll move on further. Yeah. So what investigations did you have you done for this patient?
Sir, for this
patient, before going to that, I think Dr. Venkat already asked you about types of burns. And yes, do you know it's the Jackson's burn model zones? We have a zone of coagulation, we have a zone of stasis, and then we have a zone of hyperemia.
Yes. Coagulation is the central zone, sir. After that, hyperemia and edema and hyperemia, sir.
Okay. And then the fluids, coming to one question about the fluids, how long do you give fluids? That's what one doctor asked. How long do you give fluids? So you discussed about the Parkland formula and Brooks, modified Brooks, and the other formulas are Evans formula. In that they give normal saline 1 ml per kg for percentage of burn, and then they give albumin 1 ml per kg per kg for the percentage of the bones. And then the other formula is latest formula. In that they give Ringer's lactate and the FFP. So how long do you think we have to give fluids to the patient?
Sir, first 24 to 48 hours is the most important phase, sir. First 6 to 12 hours, the initial resuscitation should be done. And after 24 to 48 hours, once I see that thing and my urine output and all the parameters are normal, then I would slowly reduce the requirement fluid and maintenance fluid, sir.
So 36 to 48 hours after that, you must go to the maintenance fluid. There's no, like we are not giving resuscitative fluids, okay? So what investigations you would like to do at this point of time for this patient?
Sir, first and foremost, I would do an ABG to rule out the other metabolic parameters, and co-oximetry comes in our ABG, so I would try to rule out the carboxyhemoglobin.
Yeah, can you show that ABG for the benefit of other students? Can you show the ABG done in your hospital with co-oximetry? I have seen that.
Generally, we get it like this, sir.
Yeah.
Carboxyhemoglobin 0.03%. This is at a later time, sir. And generally, we get it like this, sir.
Okay, good. Okay, go back to the previous slides.
So then I would do a complete blood picture, sir.
Okay.
Electrolytes, serum creatinine, and coagulation profile for this patient, sir. Because she was a CAD patient and she was on antiplatelets, I would like to do a coagulation profile also.
Okay.
I'd like to
any
do
role for CPK, CRP?
Sir, CPK, CRP, sir. This patient is more of a thermal burn injury, sir. She is not an electrical burn injury. So, and her urine output also was good. So I wouldn't do a CPK, sir. But CRP will be high, sir.
Yeah, CRP, one value won't tell us anything, but if you monitor serial CRPs, you may know the trend, how it is going. And anything else you do, any LFT, or at this point of time, do you require any other investigations?
Chest X-ray I would do, sir, to see any.
And 2D echo?
2D echo I would do, sir.
Okay, is 2D echo. Okay, okay, then go ahead with your presentation. One important aspect we have to discuss here is analgesia. Analgesia is very, very important for this patient. Do you think this patient will have pain or not?
Yes, sir, because she had second-degree burns most of the places, and even in third-degree burns also, the surrounding structures will have pain, sir. Burn area per se, it may not have pain, but the surrounding structures with edema and with the hyperemia, they will have pain, sir. Okay. So I give her analgesia with opioids and paracetamol also, sir.
Okay. Opioids and paracetamol. Paracetamol, opioids. What opioid you want to give?
Benzodiazepines also I can give. Benzodiazepines.
Benzodiazepines. Why do you want to give benzodiazepines for this patient?
It will calm her, and there are lots of patients who have allodynia and hyperalgesia also, sir. So those will be taken care of.
This patient, as of now, I think the patient is not in delirium, or the patient is not restless. You said the patient is no altered sensorium. So if the patient is in delirium, if the QTC is normal, then we can consider haloperidol, or we can give morphine. In morphine, you can give fentanyl, you can give alfentanil, any narcotic. And then if you have otherwise, dexmedetomidine is a good, it gives some sedation and then pain relief. And then the other important analgesia is ketamine analgesia. 1 to 2 milligrams per kg per hour. Ketamine also can calm the patient, and then it can prevent tachyphylaxis with opioids. And then what else you can give? Opioids, ketamine, dexmedetomidine, and then in some centers they use patient-controlled analgesia pumps. And then if you have a patient-controlled analgesia pump, PCA pump, that is the best thing you can give to the patient. And okay. Analgesia. Then okay, go ahead with your presentation.
Okay, Karthik, present the case. Next, let's summarize the case and then we'll see.
A 72-year female patient was brought to Yashoda Hospital with alleged history of flame burns of mixed type, approximately 70% of body surface area, according to the rule of Wallace.
Okay, 1 second. Go back to that slide. So, Karthik, you said you had actually calculated the surface area by different formulas. You said you had graded the burns in different areas by either it is a superficial burn, partial thickness deep burns, or full thickness deep burns, then deep burns, then extensive burns. Now you should say which are called minor or which are called moderate, which are called severe. How do you actually classify the severity of the burn and you grade them? Which patient need which kind of care? How do you know or decide that?
A full thickness burns of greater than 5% or partial thickness burns of greater than 10% or burns in children or burns over the face, thorax or chemical burns or inhalational injuries are supposed to be severe burns and they need to be treated in the ICU, sir.
Okay, what are minor burns? What are major burns? How do you actually treat them? Where do you treat them?
Any burn percentage of less than 10% without hemodynamic instability and not on the major areas, it is considered to be minor burns, sir. They can be treated at OP basis and with normal oral fluids and oral medications, sir. No need of IV fluids for them. If it is 10 to 20%, it is moderate burns. More than 20%, they should be admitted into the ICU and then treated.
So we need to classify, Dr. Karthik, which patients can be managed at OP basis, which patients needs a hospitalization, which patients need a special burns unit, that is intensive care unit. So I'm asking which patients you will manage OPD, which patient you will manage in the hospital without even you have a burns unit or intensive care unit, and which patients need a exclusive burns unit.
Patients with full thickness burns of greater than 5% body surface area.
Yeah, I understood that. That needs a ICU care or a specific burns unit. Okay.
Yes.
So even though it is more than 5%, full thickness or extensive burns can cause a catastrophic issues.
Yes.
So which patient you will manage in OPD and which patients in the hospital?
Sir, less than 10% with 10% of burns and hemodynamically stable patients, sir, in OPD, sir.
And hospital?
In hospital, 10 to 20% of burns and who may have a risk of worsening, sir.
Okay, you said the initial resuscitation, okay, with a different kind of fluid, A, B, C, D, E, all that. So once initial resuscitation and A, B, C, D, E is taken care of, then as Dr. Subba rightly pointed out, you need to take care of analgesia, and we discussed about different modalities of analgesia. What are the other different areas which need to be addressed? First, volume resuscitation, A, B, C, D, E, then you said fluid, then analgesia. After that, what are the other things you look after in this burns patient?
Sir, first thing after this primary survey, I would go to the secondary survey, sir, to see for head-to-toe examination, to see for any other traumas or anything, sir.
Yes.
Then I would, once I start the fluid resuscitation and I get the labs and I do a thorough checking of the patient, then I get a exact percentage of burns and I would monitor my fluid resuscitation and I would modify my fluid resuscitation according to the formula, sir.
Okay.
After that pain, anxiety, after that I have treated, then I will go back to my labs and depending upon the labs, I would try to take care, sir. And before this, I will take a thorough history from the attenders, sir, so that it can give me a brief idea about what exactly we are dealing with.
What are the other components of the management of burns after initial resuscitation, fluid, analgesia? Which are the other components you are anticipating?
Stress ulcer prophylaxis and feeding, sir.
Okay, nutrition. Go ahead with one at a step.
Yes, sir.
Okay, stress ulcer prophylaxis. Any other prophylaxis you need to give?
DVT prophylaxis also we can.
We can or we should give?
Should, sir. We should.
Okay, and what are the other possibilities of coagulation issues in this patient? Other organ dysfunction, as you mentioned.
She had a CAD, sir. So the cardiac damage may be seen in burns patients. So I should keep in mind about that and get a 2D echo done.
So coagulopathy, LFT derangement, as you said, renal derangements, all need to be kept in mind, and those need to be addressed in them. Any role of antimicrobials in the initial stage, and what is your stand on that?
No, sir. If it is a clean wound, no contamination, there is no role of antibiotic for it, for burns.
So what is the immediate threat on the first 24 to 48 hours in these patients?
Hypovolemia is the immediate threat, sir. On day one, hypovolemia is the primary importance.
So in these patients, when they come to our ICU, we see many of them in initial 24 to 48 hours also. We see a severe SIRS response in them with a tachycardia, high-grade fever sometimes. We also see hemodynamic instability. We also see a high lactate levels. What is the reason for all that?
Sir, basically because of the capillary increased vascular permeability and capillary oncotic pressure, decrease in the capillary oncotic pressure, there is fluid is generally shifted into the third space, and there is edema, sir. Because of that, there may be lots of other complications.
No, I'm asking burns-induced systemic inflammatory response.
Yes, sir.
In the first initial 24 to 48 hours,
Sir,
how does it manifest?
it manifests as hypotension, sir.
So it's a kind of a severe chemokine and cytokine storm-like thing where you actually see a lot of severe SIRS response in them. In the initial 24 to 48 hours, you may not actually really face many of the times as an infection as an initial challenge, but the SIRS will be an initial component of them. Many of the actually audience are trying to know insulin levels, C-reactive protein, and sometimes they also are talking about tachycardia. So what are we talking about? The patient is not infective. The patient is having any burns and he is tachycardic. He is requiring in a high catabolic state. So what we are talking about?
Burns shock, sir.
A burns patient without an infection, having a high heart rate and having actually high catabolic state. What is that called? With a loss of muscle mass, a high C-reactive proteins, which we are talking about, insulin resistance, all that. Many questions were asked about insulin resistance.
Yes, sir.
So what we call about?
Because of burns, it is a hypermetabolic state in burns. Sir.
It's considered as an hyper-attenuating hypermetabolic state in burns. That's another component which has been in debate on the last maybe a decade or so. What is a hypermetabolic state in burns?
Sir, in burns, the catecholamines are released, sir. In the catecholamines like tumor necrosis factor, IL-6, and all these things are released. And this in turn causes the cytokine storm, and which causes the increase in the vascular permeability, which causes the edemas.
What are the things will happen? You see, there will be a high protein and lipid catabolism, rise in C-reactive protein, insulin resistance, increased energy expenditure, increased body temperature, increased infection rate, increased heart rate, high metabolism, and these all can actually further vicious cyclically deteriorate these patients. So how do we manage this hypermetabolic states in burns?
Sir, hypermetabolic state, actually, there have been trials of using beta blockers and oxyldronone, sir.
So what is oxyldronone? How it helps?
Oxyldronone is anabolic steroid, sir. Testosterone analog, sir.
So what are the other things? You said beta blockers.
Yes, sir. Propranolol can be used, sir, to decrease.
Okay. How do you actually manage nutrition? Subba can take over because nutrition been a part of you as a favorite topic. Subba, nutrition in burns, you can take over. How he wants to give nutrition in them?
Yes. Yeah. And hypermetabolic state, is there any role for glutamine to prevent multi-organ failure? Did you see the latest paper in 2021, which was published in severe burns role of glutamine? Dr. Karthik?
Previous study I have seen, sir, there was no negative effect, sir, but glutamine, selenin, and arginine along with vitamin C, which have been given, sir.
Okay, so they did not find any benefit, but the new paper which was published in, I think, Lancet 2021, so the role of glutamine in preventing multi-organ failure in severe burns. Okay, and So how do you give nutrition in this patient? What are the challenges, and then how do you give nutrition?
I would try to start feeding the patient as early as possible, sir, trying to prevent the gut bacterial translocation, sir. And
Okay.
If when the patient is in a hypermetabolic state with such a huge body surface area, then I would try to give high protein diet for these patients, sir. High calorie, high protein diet.
High protein means how much protein you would like to give for this patient?
Minimum of 2 gram per kg body weight, sir, protein.
First, tell me how many calories you would like to give, and how do you calculate the calories in a burns patient?
According to Curare formula, sir, 25 kilocalories per kg body plus 40 kilocalories per percentage of burns is the approximate calorie requirement in a burns patient. So in this, approximately 50 to 60% carbohydrate and high protein diet I'll give, sir. Minimum of 2 gram per kg body weight.
And what is the problem with Curare's formula?
Curare's formula gives low amount of protein, sir. Actually, the requirement of protein is much higher in the burns patient, hypermetabolic state.
And then it overestimates the calories in the patient, right?
Okay.
So what are the other formulas for giving giving calories in burns patient?
So one other formula, it is in protein, sir, 1 gram per kg body weight plus 3 grams per percentage of burns, sir. Harris-Benedict formulas.
You have Harris-Benedict formula, and then you take standard Harris-Benedict formula, and then you add multiply with the stress factor. The stress factor, it depends on the percentage of burns. If the percentage of burns more than 40%, then you have to apply 2. So in some people take of both form based on the Curare formula, you calculate the calories, and then you calculate based on the Harris-Benedict formula, and then you take average of both. Okay. So how do you monitor the nutrition? What are the markers we have?
Sir, wound healing, sir.
Pre-albumin and albumin, any role? And then if you can pre-albumin and albumin, and then you transthyretin, other markers, and then you can monitor the weight of the patient also. Weight loss in 30 days or weight loss weekly weight, you can monitor. You can monitor that. Okay.
How early you will start, Karthik? Enteral feed or parenteral feed?
As soon as possible, sir. If airway is patent and everything is, but as soon as 4 to 6 hours, I'll start off the feeds.
So within 24 hours, if you feel feed. What is the role of the nutrition in recovery of these patients? So why do you think nutrition and protein is important in them?
For wound healing, sir, for better wound healing, nutrition is very important.
So when you how you will start and how you will increase, or you wanted to continue to be the same throughout?
No, sir. After the phase of CIRS response is decreased, sir, into the once the gut tolerance is good, sir, slowly will increase, sir. In the starting, we'll keep at a lower rate, sir. And for a continued phase of nearly 6 to 8 months, we'll give high protein feed on this.
Okay, what is the role of antimicrobials at this stage? You said prophylactically there is no role. So when you will use antimicrobial, and how it is going to help you?
If my patient is showing any signs of burn sepsis, infection in burns patients where the temperature is more than 39 degrees or there is hypothermia less than 36 degrees, or heart rate is more than 110 after adequate resuscitation, tachypnea is there, or new source is there, or whether if I'm having a culture positive sepsis, then I will try to give antibiotics. Or if there is any soakage and foul smelling from the skin, the tissue, local tissue, then we can.
Dr. Karthik, all of them, whatever you mentioned, are seen in burns. Tachycardia, hypotension, foul smelling discharges, and probably your hypothermia, all can be seen in burns. But how do you differentiate between a infection and a burns related SIRS response?
After adequate resuscitation, and also if the patient is having low urine output and and tachycardia and all those things, then positive blood cultures, then we start.
Blood cultures. So what are the different ways of these patients can get infected? What are the different reasons why these patients get infected?
The absence of the skin barrier, when it is lost, the burn itself can be a source, sir. Any other lines which we place, those may be source of infection, sir, like central lines and Foley catheter and all.
Okay. So it can be line-related sepsis, it can be endotracheal tube-related VAPs, it can be the burn site-related infection. So all this can be source. So the importance is in this, as you said, many of these burns patients will grow one or the other organism. So how you will differentiate between a patient who has a true infection, deep tissue infection, versus just a colonizer there?
The colonies, the number of microorganisms grown in that particular area should be more than 10 to the power of 5, sir. Then we take it as a positive.
Any other mechanisms you know how to differentiate? See, many of the times practically at the bedside, many of us had a very tough time in differentiating between burns related SIRS response and an infection there. Okay. And many of us tend to start prophylactic antimicrobial. The reason why we do it is sometimes not next to impossible to differentiate between a real infection versus a SIRS response. But as you said, the colony counts, and if you have a histopathological chunk during the dressing, if your surgical colleague can give you a histopathological chunk of tissue, if you have an intercellular pathogens, then if there is a cellular infiltration, then probably you can make a difference between a deeper tissue site infection versus a colonization. Because many of them, if you take a superficial swabs from this burn wound, they will grow one or the other organism. Okay, to identify a bacteremia from the surgical site or a central line related bloodstream infection, probably you need a blood culture, or you need a fresh urine catheter culture, or you need a sample from the bowel or a endotracheal aspirates. So the role of prophylactic antibiotics has been debated, and it could not prove any benefit. It most of the times has created some kind of resistance. So a prophylactic antimicrobial is generally avoided. So once you decided to initiate an antimicrobial, what will be your choice of antimicrobial in that?
My choice of antibiotic would be antibiotic with anti-pseudomonal coverage as well as gram-positive coverage.
So what are the other reasons? You said it is a loss of skin barrier is one, yes, different devices is one. Any other important thing which plays a role? Why
gauze,
these patients?
The gauze which we apply also can.
Anything else? Is there any immune paralysis or immune dysfunction happen in them?
Yes, sir.
There is a gross immune dysfunction happens in them, so that the normal pathogens, which are not a real problem in a normal immunocompetent patient, can be a cause of them. We have also seen there is a lot of leukopenia in the initial part, thrombocytopenia in the initial part. There is a lot of also in the second week onwards, when you use a high-end empirical broad spectrum antimicrobial, you may also land up in fungal infection in them, and loss of gut barrier, loss of skin barrier has been considered a risk factor for even fungal infections in them. So what is the common time where you get these infections?
5 to 7 days, sir. From 5 to 7 days, if my patient is still having fever and showing other response.
So initial 24, 48 or 72 hours, you will deal with more of a burns related hypermetabolic state, or burns related systemic inflammatory response syndrome, or a cytokine or a chemokine storms, which can cause multiple organ dysfunction. But later in the end of the initial week to second week, you land up in more of a infectious etiology related challenges. So you initially from a hypovolemia, from a systemic inflammatory response syndrome, from the burns you will slowly shift to an infective origin, causing multi-organ dysfunction, causing multi-organ failures in them. So that is where I think when you are dealing a deterioration in the second part of the week or in the second week, you tend to have a reason to think that this probably deterioration is more for infection than it is related to the burns. That's what we see in most of the situation. So, sir, go ahead.
What are the common organisms you think can cause can infect burns patient?
Most commonly it is gram positive, sir. In the starting, it may be Staph aureus and Pseudomonas, sir. These two are very common, sir.
It can be anything. In fact, it can be anything. It can be MRSA also. It can be coagulase negative staph, or it can be VRE. If it is later part, it can be VRE. So it can be gram negative, wide spectrum like Klebsiella, Pseudomonas. We are seeing more Klebsiella. Before, as you rightly said, Pseudomonas was more common. We used to cover Pseudomonas. But in our burns unit, we see more like we were seeing Acinetobacter. Now we are seeing Klebsiella. I think Dr. Venkat also will agree with me. And and then
yeah, I completely agree, Dr. Karthik. As you rightly pointed out, if a patient doesn't receive any antimicrobial and the patient comes immediately after a burns injury, you may see the common pathogens like gram-positive cocci or some Pseudomonas may be the common organism. But once the patient is in ICU for a longer period, then your ICU organisms become the most common organisms. For example, if your nosocomial infections are due to Klebsiella or Enterobacteriaceae family, they became common. If it is Acinetobacter, which is common in your ICU, they became common. I completely agree. They are the common organisms which we also do face in burns unit, not typically the gram-positive. The reason is many of our patients tend to receive a broad spectrum prophylactic antimicrobial before they come to us, and they will be on these antimicrobial for a longer period. So that makes them a selection pressure to get a drug-resistant bacteria being there as a common organism. So
and
what are the...
you can get and a fungal also, Candida, aspergillosis, or you can get viral infections, CMV. You can have herpes simplex, or you can have varicella zoster reactivation. It can be anything. So when the patient develops infection, it can be anything. We have to closely monitor these patients. We have to send appropriate cultures, and then we have to start appropriate early antibiotics. And then you can obviously measure procalcitonin also to differentiate whether it is sepsis or burn-related systemic inflammatory response syndrome. Okay.
So we discussed about the systemic management. What is the local management of burns?
Sir, mupirocin ointments or silver nitrate can be used, sir. Silver salidin was also used, sir.
No, I'm asking Dr. Karthik, when you have a different grades of burn, they are superficial burns, deep burns, extensive burns. Sir, how do you locally manage them?
Sir, locally, first is depending on if there is SR formation and there is a compartment syndrome, then a escherotomy. First is
what are the different, if a patient has an extensive superficial burns, what are the different kind of dressings, skin aids which has been available now, and you routinely see your surgeons being helping? And is there any scientific role of those things?
Sir, collagen application, biofilm applications can be placed, sir.
So in which burns, in which category of burns you allow them or use them?
First and second degree burns only, sir.
It's not in superficial. It's only in superficial burns, not even how they help.
Sir, sir,
how these dressings help?
Sir, they prevent the infection and they
okay, they give a barrier. They may prevent infection. One, anything else?
And biofilm.
Collagen sheets which they use. What are the problems when you have extensive superficial burns?
The skin, the wound healing is delayed, sir.
After other than your what you said, infection, what are the other things?
Edema will be there.
So it helps in early epithelialization. It prevents the evaporation of water vapor. It also decreases the pain threshold in them. You also mentioned about the component of pain is very high when it comes to superficial burns, whereas in deep and extensive burns, because of why there is no pain in deep burns and extensive burns?
The nerve root endings are not.
So the nerve root endings get burned. So the pain is relatively milder than superficial burns. One. Then what are the other things? One is collagen seed. The other thing you said antimicrobial seeds, different kind of chlorhexidine dressings and wax dressings which were used. Anything else we are nowadays using? We have a national burn center now.
Yes, sir.
We have a different. What are the other things?
Skin banks.
There are skin grafting. There are different kind of skin banks available, where now we are also doing a skin grafting from a skin banks, because these kind of 70-80% burns cases, you may not have much skin left. So what is the management for deep burns and extensive burns?
Deep and extensive burns, first we debride the burns, sir. We see for a healthy tissue. Then from there, the skin grafting can be done, sir. The autologous or xenograft can be placed for those patients.
So these patients need extensive debridement in initial part. The whole burn tissue need to be debrided in a phase-wise manner till they get an healthy and perfused or vascularized tissue. And then they look for a grafting or a flapping in the later part. But the initial part, it will be more of a debridement and all that. So what are the other components of other than these? What about psychosocial aspects in a burns patient?
The primary cause of burns in this particular patient, it was an accidental burn, sir. For some other patients where they have a suicidal tendency and all those patients, psychiatric opinion should be given. And for other normal patients also, psychiatric opinion should be given so that they have a moral boost and for their psychological recovery, we have to be.
There is a prognostic prediction scale which Dr. Subba was discussing. So in which category of patients where you will prognosticate for a comfort care? You will not suppose a patient with 70 years with multiple comorbidities came with 85% of burns from a poor family background coming to a very big corporate hospital where almost one day's hospital charges are more than the whole family's earning. So which are the prognostic marker which should guide you to palliate them?
More than 40% burns, age more than 60, and inhalation.
Scoring system I'm asking about. Again, you don't tell me the severity.
Brooks.
Already Dr. Subba Reddy spoke about it. One for when your age plus
percentage of burns, sir.
If you have an inhalational injury, that again adds another
17%.
So this is called modified Brooks. So inhalational injury will add another 17. So if that is more than 140, then you may have an option of counseling the family for a palliative care. Expecting this person's recovery will be very minimal, or there is a non-existence of a recovery. These patients may go for a palliative comfort care rather than being abrasive, because it has been documented that most of these patients don't make it. So in a resource limited settings, in a families with a limited resources, you may palliate them in those situations. So by any questions from that side?
Yeah. When it comes to dressings, basically the dressings are classified into three types. The one is the traditional dressings. We use Vaseline gauze, or we use silver sulfadizine, we use elamine pads, and then we have synthetic dressings. As you rightly said, we have artificial skin available. We have now we are not using these traditional dressings because they will stick to the skin. The silver sulfadizine and all, it will become black and then it will stick to the skin. So we use more gel based preparations. So these are better actually, artificial skin, hydrogel dressings, and then we have the natural dressings, like we have rabbit skin, we can use porcine, and then we can use now, as you rightly said, we have a skin bank now. We use cadaver skin. And then in 2000, they started one skin bank. And then for 9 years, they were not started again. In 2009, I think, again, they started one more. Now we have a lot of skin bank. And then even the NGOs are promoting about skin donation. Generally, cadavers, they take only liver, kidney, heart, lungs, and all. But now they are educating the people about the skin donation, because a lot of these people are very poor people. Burns patients are poor people. So cadaver skin is cheaper than going for all these artificial synthetic dressings. So this is about and Dr. Mahesh Naik, I think he was writing about fish layer dressing. Yes, fish layer dressing can be used. And traditionally, if you see in our previously, when these dressings are not available, they used to put plantain leaves, banana leaves on the burns patient. So these are the types of dressings, and then to prevent fluid loss, and then to promote epithelialization. So, and then when you're talking about trace, like nutrition, we didn't discuss about the trace elements. And then somebody was asking about role of vitamin C. So the vitamin C, what is the role? It improves, it prevents the capillary leak, fluid creep it can prevent, and then it can help in collagen formation, better wound healing, and then improving the immunity. And any role for trace elements, Dr. Karthik? Replacing selenium with deficiencies in these patients?
Omega-3 fatty acids, zinc, selenium, and all. Previous study, they have said it is no danger, but we can use them, sir. No major benefits or no disadvantages of using them.
No disadvantage. And somebody was writing about the placenta for dressing. We can use even amnion for the dressing, placenta for the dressing, for the burns dressing, we can use it. So, so we have almost, we completed all the points, I think. Are we missing anything? Or so
what are the chronic long-term complications of this burns patient?
Long-term, yes.
Sir, long-term complications, sir. Basically, these patients have a CIRS response for a longer duration of time, sir. First one. Second one, psychosocial disadvantage. The scar formation, and they may have a scar formation and
contracture and scar.
Contracture.
So this can be also lead to difficult airway management in the later part, disabilities. So this all will be a challenge, and post-traumatic stress disorder will be a phenomenon in most of them. There are a few questions related to de-resuscitation. Dr. Subba, you wanted to talk about the de-resuscitation in them. We learned to see these patients when we resuscitate them with a Parkland formula. We have recently seen these patients pour more than required urine. Sometimes we see 200, 250, 300 because we were over resuscitating. So we were putting a lot of extra pressure on the kidney to pour out the urine. So if you have a hemodynamically stable with a good amount of intravascular volume state, then you may individualize the patient's need. And a cumulative fluid balance, if a patient is getting a lot of third spacing in the initial few days, and later on, if you see the cumulative fluid balance goes very high, and you see a lot of third spacing and tissue edema, you may consider to actually even balance or de-resuscitate in those areas, but not in the initial part. It may be in the second week after the initial first week to 5 days of maintenance. And there are questions related to the 8 hours after. If a patient comes after 8 hours, how do we resuscitate them? Any comments from the Karthik?
Sir, the time of onset of burn should be taken as the first hour, sir. So the resuscitation should be as the first 8 hour bolus should be given at that particular point of time, then maintenance should be given, sir. So the point is,
it is not the point of burns. It is the point of hospital contact where the fluid resuscitation starts. That's what you mean to say?
No, sir. It is the time of burns, sir.
Okay.
It is
Time?
the time onset of burns.
Onset of burns is time 0, sir.
Okay, no, I'm asking if the patient, the question is, the patient comes after 8 hours.
Sir.
How do you restore the fluid?
Sir, the first 8 hours, the half of the fluid should be given as bolus at that
Patient comes to your hospital after 8 hours.
Yes, sir. At the total calculation should be done and half of the fluid should be given as bolus at that particular point of time.
And again, it's not like complete bolus at that point of time. Again, that can cause fluid overload in these patients. So we have to give increments, and then we have to see generally we give over a period of 8 hours. And then, but if the patient is coming to you after 8 hours, and then you cannot give all that fluid at a time. So maybe slowly we have to give fluid according to the calculation, 200 ml or 250 ml per hour or 300 ml per hour, and then we have to monitor the you have the ultrasound, and then you can monitor for the fluid overload. And it's a very tricky thing. You cannot give entire thing at a time.
What we actually mean is if the patient comes after 8 hours and he has a 70% of burns and you need 5 liters, 6 liters of fluid, you probably cannot push them within a 15 minutes or a half an hour or an hour time. So you need to readjust that over the next 24 hours or whatever time you left of 18 hours or so. That's what is probably it meant. So we don't have actually a time cutoff for after 4 hours, after 8 hours, after 16 hours. It need to readjust it to the rest of the time, giving over probably another 3-4 hours of the initial bolus and probably readjusting the whole total fluids. But it cannot be resuscitated in the same point of time of the initial 8 hours fluids. So that will be a huge fluid if given.
The key is securing a good IV cannula, 2 large bore IV cannula, give 1 or 2 liters, 2 liters, 3 liters, and then slowly over a period of half an hour, 45 minutes or 1 hour, and then monitor for fluid overload. Because as you said, in your patient, elderly patient, coronary artery disease patient, and she will have some amount of diabetic nephropathy. So we have to be careful in giving too much fluid.
So after 48 hours, mostly we get abdominal distension when we start feeding immediately after 24 hours. How to prevent it? So this is what exactly Dr. Subba Reddy was pointing out. Most of these patients with this kind of major burns will have ileus. So that ileus will create this problem. So you need to probably give a prokinetic, maintain or look for the dyselectrolemia and see whether we can reinitiate with a trickle feed and then slowly go up on the fluid, and don't be very aggressive from the beginning so that you may have this problem. So treat the ileus, treat the dyselectrolemia, and give some prokinetic in the form of metoclopramide or so, and probably you can consider re-feeding them. Any other?
What of these patients require nasogastric tubes, and then even if the patient is conscious or eating, so I have seen like when you do dressing, and then when you put them on prone position and all, they cannot eat. So always better to have a good nasogastric tube, and then give start trophic feeding. As Dr. Venkat said, that itself will promote pancreatic circulation and improves the ileus. And then if not, then we can consider prokinetics in these patients. And then stress ulcer prophylaxis is mandatory for these patients.
You have any slides to complete, Karthik? Complete them.
Sir, actually on day 1, pain was VAS at 6/10. There was a difficulty in intravenous actions and hypotension was there, sir. Treatment, aseptic dressing with collagen application and IV fluids at 2 liter bolus and 500 ml per hour, followed by 250 ml per hour according to Parkland formula was given. And analgesia and other supportive care was given. On day 2, anasarca was there. So we have started albumin infusion, sir. These are these things, and cultures came to be Klebsiella positive, sir, which is sensitive to meropenem. She had a infection. So post-infection, she went into sepsis, and after antibiotic escalation, patient recovered, and she was discharged to room sites.
Next slide.
On day 5, she had hypotension, decreased urine output, altered sensorium, and metabolic acidosis. Patient was intubated, vasopressor support was started. Antibiotics were escalated to meropenem. Debridement was done bedside, and rail tube placement and RT feeds were started. blood cultures were sent, sir. Later, she started responding well to the therapy. No fever spike. Vascular support was weaned up gradually and was extubated. And later, she was discharged out of ICU.
So this is what typically we see in post second half of the first week. Most of the infective causes happen in that time, I mean the second week also. So any other things, Subba? To summarize the whole case.
Yeah, to summarize the whole case, definitely it's a very, very complex case with major burns, elderly lady, and with high mortality, but very well managed right from your fluid resuscitation. And if you look at exam point of view for all the students, what are the important points when you are discussing about burns patient? So they talk to you about the fluid resuscitation, and then they talk to you about the fluid creep, and then they will ask you, how do you prevent fluid creep? What are the strategies you have about fluid creep, or how do you de-resuscitate these patients after resuscitation? And then any role of albumin in these patients. Then comes to the analgesia, and then comes to the classification of burns, and then the extent of burns and types of burns they ask. And then about the nutrition, what are the types of formulas we have? How do you calculate protein? How do you calculate the calories? And then inhalational injuries, carbon monoxide poisoning, cyanide poisoning, they ask. And then we talk about in the nutrition itself, we talk about role of trace elements, and then they talk about, they may ask you, how do you give anesthesia for these patients when you're taking the patient for dressing? These people, they will have too much pain, and then you need anesthesia for this patient within 48 hours. If you are using what relaxant, you can use dexamethasone, succinylcholine you can give, and then if it is after 48 hours, and then we can go with either vecuronium and these muscle relaxants. And then and infusions, propofol infusion, dexmedetomidine infusion after burn dressings. And then when they're doing sclerotomy, how do you manage the airway, and then how do you manage the compartment syndrome? And these are the questions generally they ask you in the exam. After that, they talk to you, they ask you about the dressings, and dressings, and then the role of plastic surgeon, the surgeries and all, and then about the prognostication of these patients, and then what are the long-term effects, and then what are the social problems we have, psychosocial problems in these patients. We almost discussed everything, and then we need to the electrolyte imbalances. During initially we see hyperkalemia, rhabdomyolysis and all they'll ask you. Later in any hypomagnesemia or hypophosphatemia these patients will have during later electrolyte management. And these are the questions generally they ask you in the exam. I think we covered all the aspects regarding burns.
There were few questions post your information, so probably we'll just wind up them. There were questions. This patient had an altered sensorium on day 5. Yes. Dr. Karthik, why do you think this patient had an altered sensorium on day 5?
Probably because of the hypotension and initiation of and patient was going into sepsis, sir.
So hypoperfusion, one, cerebral hypoperfusion. The second can be septic encephalopathy. So these are the two common possibilities at that point of time. But wherever, if a patient comes with an altered sensorium in day 1 of the burns, you will have a differential. Differentials. What are your differentials on day 1?
Inhalational injuries, sir. Trauma, sir. Direct head injury, trauma, and all those things, sir.
So inhalational injuries, cyanide toxicity, trauma, head injuries, and all that can be. You also spoke about A, B, C, D, E. We actually cut down that there. There were some good questions related to when do you actually secure the airway?
Airway, whenever the patient is having airway edema or impending airway edema, like a change of voice, or there is soot in the nasal cavity, face is there, face is involved, there is edema of the tongue, impending airway difficulty may be there. So
head and neck burns with some clues that you have an airway burns or airway injury. So these patients will later on land up in very difficult airway. when your swelling or edema gets worsened. You may have a very bad facial swelling, you may have a very bad tongue swelling, airway edema, and it will be next to impossible to intubate these guys. So maybe it will be sensible sometimes to protect the airway in advance or in prophylactically to keep it probably safe in those situations. So anything to add from Dr. Sasi?
We have covered everything, sir, including even muscle relaxants also. Sir covered that also for intubation purpose. So resuscitation we covered, and infections. Role of surveillance cultures and swab cultures, frequent swabs, any role?
Sir, surveillance culture can help us to know whether it is sepsis because of the tissue, sir. Means whether it is a cause or it is the cause of infection.
So normally guidelines will recommend at least once in 3 days to do the surveillance cultures. Weekly 2 times minimum we have to do surveillance cultures. So swab cultures in good centers, they will practice the swab cultures also. But according to swab cultures in our scenario, usually if we do, majority of times it will be contaminants.
Okay, I think with this, I actually thank Dr. Subba Reddy in taking out his precious time from his busy schedule and being available here. And Dr. Suresh Ramsubban has to attend an VIP emergency in his hospital, so he has to rush back, and he conveyed his apologies to all participants who are here to listen to him. And probably we will try to bring him back in next cases to share his teaching experience, knowledge. He has been a phenomenal teacher for all of us. Thank you, Dr. Subba, for your vast horizon of question answer sessions and experience sharing, and probably giving all our participants that experience of an exam. And thank you, Dr. Karthik, in bringing the case and being a part of it. And I thank all the participants who have joined us. And we will try to bring more and more interesting cases in the next part of this year. Our next session after the next week will be by Dr. Srinivas Samvedam and his team colleagues. So we will bring you those details in the later part of it. I also thank Dr. Shashidhar Pulagam, who is our course coordinator, who has taken a lot of effort in bringing this program into live and being a part of it. I thank IFCCM Hyderabad chapter and Dr. Subba, who is the chairperson of that, and Dr. Pawan and Dr. Madhusudan, who have been secretary and the treasurers of this organization, who are helping us in bringing this organization. I thank and conclude the session. Thank you all.
Thank you, sir.
Thank you, sir.